everyone, we are medical students from Unimas. Currently we are in orthopedic posting. In this video, we are going to show you how to perform physical examination on median nerve. The median nerve derives from medial and lateral cords of brachial plexus. It innervates group of flexor parietal muscles in the forearm, and most of the musculature present in radial portion of the hand, controlling abduction of the thumb, flexion of the hand at the wrist, flexion of the digital phalanx of the fingers. Again, the nerve allows the sensory innervation to the thumbs, index, middle and radial side of the ring finger, and the entire palmar region of the radial half of the hand. It also provides sensitivity to the dorsal skin of the last two phalanges of the index and middle fingers. The median nerve is most injured near the wrist or high up in the forearm. Low lesion may be caused by cuts in front of the wrist or carpal dislocation. High lesions are generally due to forearm fractures or elbow dislocation, but stab and gunshot wounds may damage nerve at any level. Carpal tunnel syndrome can also lead to median nerve compression.
Hello, my name is Lim Qi Chen. I am a year 4 medical student from Unimas. So today I am going to examine your hand. Are you okay? Yes. Okay. So first I will ensure the patient hand will be on the pillow, and the patient will be exposed for the upper limbs from the level of the forearm up to the level of shoulder. So for median nerve examination, we will do look, feel, move and spatial tests. On inspection, we would like to see if there's any muscle wasting based on the median nerve distribution. So we will look for any inner muscle wasting and also the anterior forearm wasting. And next, we would like to see if patient has any scars for the patient wrist, forearm and also the patient hand. So can you leave? There's no scars. For the first type of deformity, patient is unable to flex the index and also the middle finger when we ask the patient to do a fist. This is also known as benediction sign. Benediction sign is classified into low lesion and also the high lesion. For low lesion, patient is still able to flex the proximal phalanx and also distal phalanx due to the weakness of the lumbricus only. But for the high lesion, patient is unable to even flex the proximal and also the distal phalanx due to the weakness of both the FDP and also the lumbricus. For the next deformity, it is also known as apes hand deformity, where the patient thumb is adducted to the index finger. This is due to the weakness of the AB ductal pollicis but the unopposed action of the AD ductal pollicis brevis of the ulnar nerve. Next is feel. First, we would like to compare the temperature of the both palm and also the forearm. Then we would like to ask whether patient has any tenderness. For sensation, we will ask patient whether the sensation of both sides of the radial side of the index finger and also the thenar eminence is equal. And for the low lesion, patient will only have the loss of sensation on the radial side of the index finger, but the sensation of the thenar eminence still intact. But for the high lesion, patient will have lost sensation of the both radial side of the index finger and also the thenar eminence. Next is move. I will ask patient to do the OK sign. So for the normal side, you can see patient can abduct and also flex the thumb and also the index finger nicely. But for the abnormal side, patient might not be able to abduct and also flex the thumb and also flex the index finger at the proximal, distal and also the metacarpophalangeal joint nicely. For the power, first we would like to check the power of patient abductor pollicis. Next, we would like to check the power of the patient FDP. Then we would like to check the power of patient FDS. Next is spatial test. First, we would like to elicit thenar sign. So we will try to press along the carpal tunnel and also the distribution of the median nerve for 15 seconds. If it's positive, patient will feel tingling or needle pinprick sensation. For the second spatial test, which is the filing test, we will ask the patient to do the reverse hand prayer sign for 30 to 60 seconds. If it's positive, patient will feel the tingling and numbness sensation. For the third special test, which is known as Duken test, we will compress at the flexor retinaculum and wait for 30 seconds. If it's positive, the patient will feel the tingling sensation. For the fourth special test, which is also known as resisted pronation test, first I will ask patient to pronate. So when the pronation is being resisted, if it's positive, patient will feel tingling sensation. Lastly, I would like to complete my median nerve examination by doing neurovascular examination. Thank you.